I am Dr. Cheryl Walker-McGill, Chair of the NMA Allergy, Asthma, and Immunology section, and we'd like to welcome you to this webinar, Advancing Asthma Care, Prioritizing Equity and Excellence. The webinar will be led by Dr. Jackie Garrett, and key issues in asthma care will be reviewed and discussed, including clinical gaps in managing severe asthma, health disparities, and strategies for improving asthma management and health equity. A live Q&A session will follow the presentation. Dr. Garrett attended Princeton University, where she received her Bachelor of Arts degree in sociology. She received the Lisa N. Bryant Senior Prize and graduated cum laude. She received her medical education at the Morehouse School of Medicine in Atlanta, Georgia. She graduated cum laude and earned several awards, including the Leonard Toe 2007 Humanism in Medicine Award, the Morehouse School of Medicine 2007 Ross Jackson Award for Excellence in Pediatrics and Honors in Community Health. Dr. Garrett completed her medical training at the University of Pennsylvania Health System. Her specialty training in pediatrics was at the Children's Hospital of Philadelphia. Her allergy and immunology subspecialty training was at the Children's Hospital of Philadelphia and the Hospital of the University of Pennsylvania. Dr. Garrett is a board-certified allergist immunologist, and she's board-certified in pediatrics. She is a member of the American Academy of Allergy, Asthma, and Immunology, Massachusetts Medical Society, Massachusetts Allergy Society, and the New England Society of Allergy. Dr. Garrett serves on the board of the Southern New England Health Organization representing Massachusetts and established Agape Allergy and Immunology Associates, LLC, in 2022, where she currently serves as its CEO. Dr. Garrett and her college sweetheart live in Massachusetts with their 3 children. She enjoys reading, attending, and fundraising for her children's activities, walking her dog, and napping if she ever gets the opportunity. So Dr. Garrett, thank you very much for joining us this evening. And now I will turn it over for the video.
Hello, I'm Dr. Jackie Garrett, CEO of Agape Allergy and Immunology Associates, and I'm thrilled to welcome you to this program titled Advancing Asthma Care, Prioritizing Equity and Excellence. Before we get started, just a few important notes. This is an AstraZeneca-sponsored program intended to provide disease state educational information and will not present any product information. Please note that this event does not qualify for continuing medical education, continuing nursing education, or continuing education credit. Lastly, I would like to acknowledge that I have received compensation for my role in developing and delivering this presentation. Today's program will focus on 2 critical areas of unmet need in asthma care. We will begin by analyzing the clinical gaps in managing patients with severe asthma, utilizing real-world data to identify how current practice trends may be falling short in achieving optimal disease management. Following this, we will examine the health disparities which exist across all asthma severities and prevent equitable disease management amongst diverse patient groups and communities. For both topics, it's important to not only understand the substantial burden these challenges impose on patients, but recognize that we, as clinicians, have the ability to help address some of the underlying factors. As outlined in the final objective, each section of the program will explore actionable opportunities and strategies for enhancing our care delivery, with the aim of ensuring personalized and effective management that improves outcomes for patients. With that overview in mind, let's start by examining the clinical gaps in the management of severe asthma. First, we need to identify and understand the characteristics of our severe asthma population. According to the CDC, nearly 25 million people in the United States are living with asthma, of which it is estimated that up to 10% are classified as having severe asthma. These are patients who, by definition, require treatment with high-dose inhaled corticosteroids, also known as ICS, along with 1 or more controller medications, to prevent their asthma from worsening or becoming uncontrolled. Despite adherence to maximal therapy, many patients with severe asthma continue to face a significant clinical burden, with an estimated 20 to 50% having uncontrolled disease. This is commonly referred to as severe uncontrolled asthma, or SUA, and is characterized in guidelines by the presence of either poor symptom control, frequent exacerbations requiring steroid treatment, serious exacerbations leading to hospitalization, persistent airflow limitation, or a combination of these features. Across all levels of asthma severity, a primary goal of management is to achieve long-term control through a combination of pharmacological and non-pharmacological interventions. Evidence-based recommendations, including those from the Global Initiative for Asthma, commonly referred to as GINA, utilize a stepwise treatment approach in which therapy is escalated if asthma remains uncontrolled despite good adherence and proper inhalant technique. The figure from GINA presented here outlines recommendations for managing asthma in patients aged 12 years or older, with two distinct tracks that are primarily differentiated by the type of reliever medication used. Importantly, SABA-only treatment is no longer recommended by GINA for any patient, as it has been linked to an increased risk of asthma exacerbations and mortality, even in patients with good symptom control. Instead, GINA recommends that patients receive anti-inflammatory reliever therapy. For patients with severe asthma, shown here in step 5, referral for assessment of their inflammatory phenotype is recommended. This evaluation can help guide the initiation of add-on inhaled or biologic maintenance treatments for those who remain uncontrolled despite adherence to high-dose ICS-containing therapy. Please note, the use of ICS formoterol is not approved in the United States for combined use as both maintenance and rescue therapy, or for as needed only. The recommendations for ICS formoterol are based on clinical data evaluating the use of ICS formoterol formulation in strains not approved and not available in the United States. For patients aged 6 to 11, GINA provides a single stepwise treatment approach that parallels many of the recommendations for those 12 and above, advising ICS-containing therapy across all disease severities, and referral of patients with severe asthma for phenotypic assessments to guide the choice of add-on therapy, although options may be more limited due to age-specific treatments approvals. The key emphasis in these guidelines is the recommendation to refer patients with severe asthma to specialists for multidisciplinary co-management. While primary care remains essential for these patients, specialists offer unique expertise in conducting comprehensive pulmonary investigations, including blood and allergy testing for patient phenotyping, identifying less common comorbidities and differential diagnoses that may contribute to a patient's disease burden, and prescribing and monitoring injectable biologic therapies. This multidisciplinary approach, in collaboration with primary care, is crucial for optimizing the management of all patients with severe asthma. Supporting this, a retrospective analysis of U.S. medical and pharmacy claims data revealed that patients aged 6 years and older with severe asthma, whose management included a pulmonologist or allergist, demonstrated better adherence to maintenance therapies, a higher likelihood of receiving biologic treatments, and improved asthma-related outcomes. As depicted in the graph on the right, these included a lower risk of exacerbations, reduced healthcare resource utilization, and a decreased reliance on rescue medications such as short-acting beta-2 agonists and oral corticosteroids. Focusing specifically on the effects of biologic therapy, results from a real-world analysis of specialist-treated adults with severe asthma revealed that initiating biologic therapy led to more than 50% reduction in the rate of exacerbations. This reduction also extended to emergency department visits and asthma hospitalizations, all within 6 months of starting treatment compared to the 6 months prior. Altogether, these findings underscore the critical role of specialist co-management in optimizing care for patients with severe asthma. The results from the first study also highlight the critical gap in asthma management. Despite the clear advantages of involving specialists, many patients with severe asthma are not receiving the necessary care. In fact, only about 40% of patients saw a specialist in the year before or after showing evidence of severe asthma. This underutilization is further emphasized by a separate claims analysis, which revealed that a substantial number of patients with severe uncontrolled asthma do not receive timely and appropriate specialist attention or medication escalation. For instance, approximately 35% of patients hospitalized due to asthma and 38 to 51% of patients who experienced 2 or more corticosteroid-treated events did not engage with a specialist or have their treatment plan escalated within a year of these events. Given these results, along with the known benefits of specialist care, it is concerning but not surprising that treatment practices for severe asthma in the US do not consistently align with evidence-based recommendations. Specifically, data from the International Severe Asthma Registry revealed that only about 16% of US patients with severe asthma are receiving biologic therapy, whereas about a quarter are on regular oral corticosteroid therapy, defined as 90 or more days of use per year, despite being regarded as a last resort option. Prolonged corticosteroid use may worsen asthma outcomes, leading to an increased risk of exacerbations, emergency department visits, and hospitalization. As illustrated on the right, patients with severe asthma who receive maintenance corticosteroids experience higher rates of these adverse outcomes compared to those on biologics. Notably, patients who receive maintenance corticosteroids also face a greater risk of ED visits and hospitalizations compared to patients receiving neither biologics nor maintenance corticosteroids. Beyond efficacy concerns, the prolonged use of corticosteroids also poses significant health risks. An analysis of administrative claims from a larger commercial database revealed that patients with severe asthma who were continuously exposed to systemic corticosteroids for at least 6 months face elevated risk of corticosteroid-related complications, as well as hospitalization and emergency department visits due to these complications, with risk intensifying at higher daily doses. The most frequently reported complications included cardiovascular, psychiatric, and metabolic conditions, as well as bone and muscle-related disorders. Complications associated with cumulative exposure to systemic corticosteroids are well documented, and this risk is a key reason why GINA advises reserving this treatment as a last resort for managing severe asthma. Importantly, the management of acute asthma exacerbations also contributes to the risk of corticosteroid-related complications. While systemic corticosteroids are often necessary and effective for treating these exacerbations, observational data indicate that standard bursts of SCS increase cumulative steroid exposure, potentially impacting long-term health. Statistical significance for developing conditions such as diabetes, anxiety, and depression was observed when cumulative lifetime SCS exposure reached 500 milligrams. Higher cumulative doses between 1,000 and 2,500 milligrams were linked to increased risk of these complications, as well as additional adverse conditions, including osteoporosis and cardiovascular disease. As shown in the figure, these thresholds can be reached with just 1 or 2 short bursts. For instance, a typical regimen of 50 milligrams per day for 7 days can accumulate to over 500 milligrams with just 2 courses and surpass 1,000 milligrams in 3 courses, emphasizing the critical importance of achieving and maintaining asthma control. Achieving effective asthma control is not only crucial for minimizing the risk of these serious complications, but also for improving patients' daily lives. The real-world novelty study, which analyzed data from patients with severe asthma in both primary care and specialty centers, revealed heightened symptom burden among individuals with uncontrolled disease. Compared with patients whose severe asthma was controlled, these patients experienced more frequent shortness of breath, increased reliance on their rescue inhalers, greater activity limitations, and more common nighttime awakenings. These challenges can collectively impact the patient's ability to engage in everyday activities, which may ultimately diminish their quality of life. As such, the study also found that patients with severe uncontrolled asthma were less likely to rate their overall health positively, as illustrated in maroon and navy bars, with approximately 1 in 5 patients with severe uncontrolled asthma rating their health as poor or very poor. This study also highlighted the impact of severe uncontrolled asthma on productivity. Compared to patients with controlled asthma, Those with severe uncontrolled asthma were 2 to 3 times more likely to experience absenteeism, which measures the percentage of work time missed due to health, presenteeism, or the extent of impairment experienced while at work due to health, overall work impairment, which is a combination of absenteeism and presenteeism, and activity impairment, measuring the percentage of impairment in daily activities due to health. It's important to also recognize the substantial economic burden associated with uncontrolled severe asthma. These findings are based on a retrospective analysis of medical and pharmacy claims data which characterized patients with SUA according to the type of events that indicated their uncontrolled disease. The analysis revealed that across all indexed event types, patients with severe uncontrolled asthma incurred higher overall and asthma-related healthcare costs over a 12-month period when compared to patients whose asthma was controlled. Patients who were hospitalized experienced the greatest financial impact, with total costs approximately 2.5 times higher and asthma-related costs around 5.5 times higher than those incurred by patients with controlled asthma. The substantial burden and treatment gaps seen in patients with severe asthma highlight the critical need for improved management strategies. However, the impact of this condition is not evenly distributed. Disparities in severe asthma management persist across various social demographic groups and geographic regions. Racial and ethnic disparities are particularly pronounced, with Black and Hispanic patients experiencing less biologic use, increased exacerbation risk, poor symptom control, and diminished health-related quality of life compared to white patients. Gender disparities also contribute to inequitable outcomes, as women with severe asthma often report poorer health-related quality of life and higher risk of exacerbation. Age-related disparities are evident amongst older adults who have the lowest rates of specialist engagement and consequently are at higher risk of poor disease control. And geographic disparities highlight the uneven distribution of care, with variations in the prevalence of severe uncontrolled asthma across different regions. It's crucial to recognize that these disparities are not mutually exclusive, and individuals may experience multiple overlapping disadvantages. Moreover, many of these gaps in management extend beyond those specific to patients with severe asthma. In the following sections, we will examine the root causes of these health disparities and outline a comprehensive approach to achieve more equitable asthma care and enhance outcomes for all affected patient groups. To fully understand the burden of asthma and its disproportionate impact on certain populations, we need to look beyond the disease itself and examine the broader societal factors that influence health outcomes. These underlying factors are known as social determinants of health. They include the conditions in which people are born, grow, live, work, and age, all of which influence their health, functioning, and quality of life. Healthy People 2030 is an initiative by the Department of Health and Human Services aimed at enhancing health and well-being across the United States and groups social determinants of health into 5 key domains: education access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. Social determinants across all domains create inequities in opportunity and resources, leading to preventable differences in health outcomes among specific populations. These are health disparities, and they disproportionately affect socially disadvantaged populations, hindering their ability to achieve optimal health. In the following slides, we will delve into how these social determinants of health influence asthma and contribute to disparities in asthma management. One key factor is income status, which greatly affects both asthma prevalence and burden. According to data from the U.S. National Health Interview Survey, individuals living below the federal poverty line have the highest rates of asthma. This is exacerbated by research revealing that low-income patients are more likely to experience asthma-related events and encounter challenges in accessing affordable health care. Additionally, income is a multifaceted factor that influences other social determinants of health, including insurance coverage, healthcare access, education, housing, and food security. These factors collectively intensify the disproportionate burden of asthma on low-income communities. As shown in this last figure, certain populations experience higher overall poverty rates, which may further amplify asthma disparities. For example, Black, Hispanic, female, and rural residents have disproportionately higher rates of impoverishment compared to the national average. Insurance coverage plays a critical role in access for patients with asthma. Patients who are uninsured or publicly insured often face financial barriers that impact medication affordability and subsequently adherence, as well as healthcare engagement. These challenges may result in suboptimal disease management and poorer asthma control. In particular, insurance status can significantly affect critical elements essential for the optimal management of severe asthma. Compared to individuals with private insurance, those with public insurance or no insurance are less likely to receive outpatient care from asthma specialists and less likely to be prescribed biologics for their asthma treatment. The figure on the slide highlights disparities in insurance coverage among patients with asthma in the US. Black, African American, and Hispanic populations are far more likely to be covered by public insurance or be uninsured compared to non-Hispanic whites who predominantly have private insurance. While not highlighted here, Medicare recipients, a vast majority of whom are aged 65 and older, also represent a significant group that may face unique challenges in asthma care due to potential coverage limitations of public insurance. Addressing these insurance gaps is essential for overcoming barriers to effective asthma management and improving access to necessary treatments for disproportionately affected patients. Barriers to healthcare access can impact a patient's ability to receive timely and appropriate asthma management. These challenges disproportionately affect non-white and rural communities, contributing to poorer asthma control and an increased asthma disease burden. A shortage of PCPs exacerbates these challenges. In rural areas, the patient to PCP ratio is approximately 1.53 times lower than in urban areas, often requiring patients to travel longer distances for care. Additionally, African Americans and Hispanics are more likely than whites to live in areas with PCP shortages. Access to specialist care is also limited for many patients. Nearly 2/3 of rural health clinics report difficulty finding specialists, including pulmonologists, for patient referrals. Racial disparities in specialist care also exist, with research showing that Black and Hispanic children with asthma are less likely to see an asthma specialist than white children, even when having the same health insurance coverage. Addressing these access issues is crucial for improving asthma management and ensuring better disease control and outcomes among affected patients. Next, let's look at the impact of low health literacy on asthma management and healthcare engagement. A substantial portion of US adults, approximately 36%, struggle with interpreting and applying health information. This issue disproportionately affects non-white communities, those with lower educational attainment and limited English proficiency, people living in poverty, and older adults. Notably, over 75% of US adults aged 60 and older struggle with understanding medical documents, including printed materials, numerical information, and calculations, posing barriers to effective healthcare engagement. Low health literacy is strongly associated with several critical challenges in asthma management. Individuals with low health literacy are more likely to have a limited understanding of asthma, reduced medication adherence, and challenges in following asthma action plans. Together, these issues may contribute to poor asthma control and increased disease burden and diminished health-related quality of life. Disparities in asthma outcomes are also exacerbated by environmental factors. As shown in the figure, Black and Hispanic communities frequently lack access to healthy food. This food insecurity may contribute to poor asthma control, reduced lung function, and higher obesity rates, all factors that complicate asthma management. Similarly, substandard housing, disproportionately impacts Black and Hispanic families, exposing them to harmful substances like pests, allergens, and mold. These environmental triggers are directly linked to increased asthma prevalence and heightened disease burden. Long-term stress from social determinants of health may directly drive asthma disparities. Individuals from low socioeconomic status backgrounds and non-white populations often experience heightened stress due to factors including poor patient HCP communication, financial instability, food insecurity, social disadvantages, and trauma. Consequently, high levels of prolonged stress have been associated with poor disease control, reduced lung function, more frequent asthma attacks, and increased hospitalizations. This cycle of stress and poor health outcomes can perpetuate disparities and undermine overall well-being. Up until now, we've explored how social determinants of health impact asthma disparities. Now, let's shift to focus on a few key structural determinants, starting with the underrepresentation of disparity populations in clinical research. Recently, the FDA issued draft guidance emphasizing the need to include historically underrepresented populations in clinical studies, covering diverse groups across race, ethnicity, sex, and age. This guidance addresses a critical issue in ensuring that research benefits all groups more equally. When certain groups are underrepresented in research, the consequences can be far-reaching. A lack of diversity in clinical studies can limit how widely research findings can be applied, affecting their generalizability. When certain groups are underrepresented, there can be disparities in their access to effective medical treatments and interventions. Inadequate representation can undermine trust in the medical research community, making it harder to engage with and benefit from research. And exclusion from clinical research exacerbates existing health disparities, leaving underrepresented groups further behind in health outcomes. Addressing these issues is essential for advancing health equity and ensuring that all populations benefit from medical research. By failing to include diverse populations, we reinforce existing healthcare inequalities, which may impact the management of conditions such as asthma. A notable example of these inequities is the historical use of race-based correction factors in spirometry for asthma management. These factors artificially reduce lung capacity measurements for Black and African American patients by 10 to 15%, perpetuating the false notion of inherent biological differences based on race, despite genetic evidence showing no support for these adjustments in pulmonary function tests. This practice can have severe consequences. It may lead to the underdiagnosis and misdiagnosis of pulmonary diseases in racial minority patients, negatively impacting their overall health outcomes. Additionally, it can limit access to effective treatments by not accurately reflecting the severity of their condition. It may also skew clinical risk assessment, potentially increasing morbidity and mortality due to inadequate management. It wasn't until 2023 that the American Thoracic Society advocated for race-neutral equations in spirometry. These updated equations provide more accurate correlations between spirometry results and clinical indicators such as symptoms, airway structure, emphysema, and functional capacity, offering a more equitable approach to asthma management. While spirometry highlights one example, it's essential to recognize that structural determinants broadly impact asthma outcomes. For instance, research on housing mobility programs has highlighted how housing discrimination can contribute to asthma morbidity among children. These are just a few examples that underscore the complex relationship between structural factors and asthma disparities, emphasizing the urgent need for systemic changes to address these inequities. Now that we've explored the social determinants driving asthma disparities, let's shift our focus to how we can improve health equity. Addressing these disparities requires targeted strategies and systemic changes to ensure that all patients have access to the care and resources they need. As we focus on improving health equity, it's crucial to prioritize efforts for the most vulnerable populations affected by asthma. The 2020 Asthma and Allergy Foundation of America report, Asthma Disparities in America, offers a valuable framework for healthcare professionals to address these disparities effectively through direct interventions to improve asthma self-management, advancement in research and science, and advocacy for public policy reform. Effective asthma management requires overcoming barriers to ensure that all patients receive high-quality care. To address these challenges, focus must be given to solutions that enhance equitable asthma management through strategies such as implementing comprehensive training for multidisciplinary teams to help them better identify and address social determinants of health impacting asthma patients, adhering to established guidelines, and providing patients with up-to-date education on new treatments. Integrating shared decision-making into routine practices to elevate patient involvement in their treatment plans. Using standardized severity assessment tools which allow for more accurate evaluation of asthma-tailored treatment approaches. Offering culturally appropriate asthma action plans in patients' preferred languages to support better understanding and management of their condition. And expanding access to specialist care through increased referrals, ensuring that patients have the opportunity to receive the appropriate expert-based care. These strategies represent an important step in addressing barriers to equitable asthma management, setting up for broader efforts to improve outcomes for underserved populations. To optimize asthma management, especially for high-risk populations, implementing asthma self-management education programs is essential. These programs empower individuals and their caregivers by providing education on proper medication use, including inhaler technique and adherence, strategies to identify, reduce, and manage exposure to asthma triggers, and guidance on how to effectively manage their asthma during periods of worsening symptoms. ASME programs have demonstrated significant benefits, including improved medication adherence, fewer asthma-related hospitalizations and emergency department visits, reduced absenteeism due to asthma, and lower healthcare costs. Adopting ASME programs is a proactive step toward improving asthma outcomes and supporting underserved populations in managing their conditions more effectively. Empowering individuals with asthma, their caregivers, and healthcare professionals begins with access to reliable information. To support effective asthma management and education, several valuable resources are available. First, visit asthmaresourcecenter.com or scan the QR code to access evidence-based educational materials for patients and HCPs, including treatment recommendation summaries, inhaler selection and technique guides, and instructions for using an asthma action plan. Next, online resources and ASME programs are readily available from leading professional societies such as the Allergy and Asthma Foundation of America, the American College of Allergy, Asthma, and Immunology, the Allergy and Asthma Network, and the American Lung Association. And finally, many states offer ASME programs funded by the CDC's National Asthma Control Program, which you can learn more about by contacting your state health department. Addressing health disparities also requires a strong commitment to clinical research within vulnerable patient groups. As HCPs, we have the ability to bridge this gap by addressing key barriers to research participation. First, by addressing a common lack of awareness about research opportunities, which may particularly affect groups with limited specialist engagement. Next, by addressing the fear that arises from insufficient information and a lack of transparency regarding clinical research. This issue is closely tied to language barriers, making culturally and linguistically appropriate materials essential. Finally, by addressing mistrust in clinical research. Establishing a trusted point of contact who can clearly explain the trial process and its importance is crucial, as research suggests that individuals are more likely to participate when they are recruited by people they know or with whom they can identify. By focusing on these areas, healthcare professionals can help ensure that clinical research is inclusive and representative of the diverse population it aims to serve. Finally, We can drive significant change by working with community stakeholders to advocate for public policy reforms that address asthma disparities. A key initiative in this effort is the National Asthma Public Policy Agenda, which seeks to reduce asthma-related morbidity, mortality, and health disparities through targeted reform in 6 critical areas. By improving public health infrastructure, enhancing healthcare systems, addressing environmental factors, and fostering healthier environments in homes, schools, and workplaces, we can advance asthma management and promote health equity. These collaborative efforts are critical for making meaningful progress in reducing asthma disparities and improving outcomes for affected communities. As we conclude, I would like to take a moment to reflect on a key element from the title of this presentation, prioritizing equity and excellence. This phrase serves as an important reminder that achieving equity in asthma care is not merely a goal. It is a call to action that requires us to take meaningful steps to address the disparities that affect patients. Everyone involved, from healthcare professionals to researchers and policymakers, plays a vital role. By collaborating and committing resources, we can drive meaningful improvements in asthma management and ensure that everyone receives the care they need. With that, I would like to thank you for attending this presentation and extend my gratitude to AstraZeneca for their collaboration in creating this program. If you have any comments or questions, please contact AstraZeneca at 1-800-236-9933. You can also visit azmedical.com for medical information requests and access to additional resources. Again, thank you for attending this presentation and for your commitment to advancing equity in asthma care.
Thank you, Dr. Garrett. That was an excellent presentation and very comprehensive.